Hi everyone, welcome to another episode of Ask the Egg Whisperer. My version of heaven is literally doing this every single day. That would just make me feel like I have the purpose that I was intended to have, and I couldn't imagine doing anything more fun than helping people who have fertility questions, just want to get my perspective and the perspective of other fertility experts. So thank you guys for sending in your questions. If you haven't been able to tell, what I'm trying to do moving forward is to do shorter sessions so I can also answer your live chatted questions during the Ask the Egg Whisperer session. So I'm going to try and limit the emailed questions that I get each session and do shorter sessions so that I can interact with you guys live. So thank you guys for tuning in. If you have a question for me or one of the other fertility experts that will be coming on, go ahead and send it in to asktheeggwhisperer.com. It's as simple as that. And from there, I'll read your question and then we'll talk about fertility. So how about we get started? And if you can't notice, I'm wearing blue today. So this question is from Sarah. So Sarah's question is, we started trying to conceive 2 years ago and we got pregnant after 3 months of trying. We saw a heartbeat at 8 weeks one day and miscarried at 10 weeks. It then took 10 months to get pregnant the second time, and we miscarried at exactly 8 weeks and didn't have an ultrasound. We're now on month 8 of trying again. We went to a fertility clinic last month and we did a monitored medicated cycle that didn't work. For those of you who don't know what that means taking a fertility pill like Clomid or Femera with a follicle check, followed by a trigger shot and natural conception or timed intercourse at home. This last month, we did an IUI, and it was the first semen analysis my husband has ever had. The OB and fertility doctor never gave us a reason to worry about him because we've been able to get pregnant twice. Well, his count pre-wash was 35 million, 50% motility, 3.6% morphology. Post-wash was 7 million with 98% motility. We found out the IUI failed. What do you think we should do next? I ovulate on my own, but I do have hypothyroidism. My husband might also have celiac disease. So Sarah, thank you for your question. And I actually created something that is a very straightforward approach to apply to cases just like yours. I call it the ANGEL Workup or the ANGEL method. I know you guys have heard about all my methods, like the balls method and the tushy method, and they're not a joke. They are for real, legit approaches to fertility care that so many fertility doctors take. But sometimes it can seem confusing and overwhelming for patients to know what to do next when you're in this situation. So I'm just going to break it down for you. First, the A. Look at the anatomy of your uterus. Ask the question, is there a possibility that there's something in my uterus that's preventing a pregnancy from growing past a certain point? Another part of the A in the ANGEL Workup or method is your age. You didn't share your age with me, but we do know that as we get older, and I know I'm not saying something that you guys don't know already, it's just harder to get pregnant with a healthy embryo. And that's just kind of how it is. I mean, I wish I had some magic potion or secret sauce. I mean, I'd like to think I have a secret sauce, but something I can do to turn bad eggs into good eggs or good eggs into even better eggs. But unfortunately, I just don't have that. So looking at your age and your AMH level is super important. And then the other A is a workup for autoimmune conditions, like, for example, if you're a carrier for lupus anticoagulant, or if you have antiphospholipid antibody syndrome. So these are things that a reproductive endocrinologist or a OBGYN who understands how to care for women who have pregnancies that have miscarried, especially more than twice, could do this workup for you. But now that I'm mentioning it, you can now ask for this approach and these tests to be done. The N is looking at your nutrition, and it's not just yours. You brought up a really good point about how your husband might have celiac disease. We know that men who have celiac disease could have lower sperm counts. So get that evaluated and worked up, and potentially you can see his counts improve. And the G is looking at your genetics, both a carrier screen for both of you and for your husband, especially a sperm DNA fragmentation test, I think will really help guide you because, as you guys know, every embryo is a sperm and an egg and equally a sperm. You know what I mean? So we can't just sugarcoat the sperm results. So I think it's important to do another formal semen analysis. And the company that I like, there's so many different ones out there. There's Yo Sperm Test, which is great. It plugs into your phone, literally. It's a little less expensive than Meet Fellow, MEET fellow.com /Egg Whisperer is a code that you can use for, I think it's like $20 off or something like that. And then the DNA fragmentation test can be ordered online without even a doctor ordering it for you. So a lot of these things can be done in your own hands, on your own time, without relying on a doctor or having someone say no. But I would say most physicians, after hearing what you've gone through, would agree that this is the type of workup that you would probably want and need. And the E for Angel is endocrine evaluation, looking at, for example, if you have a thyroid issue or diabetes. And lastly, looking at your lifestyle and the medications that you're on and really evaluating what's going on in your life as far as nicotine exposure, alcohol consumption, your body weight, how much are you exercising, how much are you sleeping. So really looking at that, your lifestyle is exactly what I would want you to do. And know that even though you've had the number of pregnancy miscarried that you've had, there is still hope for you to have a healthy pregnancy. Unfortunately, pregnancies that miscarry are part of the normal human experience for too many of us. And I'd like to create a miscarriage, I don't know if it's a miscarriage revolution, but almost like a fertility revolution for everybody so that you can have these tests done even after one miscarriage. Look at the genetics of the pregnancy that has stopped growing to teach you about what you should know and what you should do next. Too often women are told, oh, it's just because of your age, or oh, it's just because it's genetically abnormal. But unfortunately, that's not enough for almost most of us, because no matter what I tell a patient, she actually still wants to have an answer and a reason. So thank you, Sarah, for asking your question. And I hope that my answer will help you now go to your doctor with this approach. And you know now what questions to ask, but you're definitely asking all the right questions. So this next question is from Jill. Jill is asking, I want to know how much the LH numbers weighs in determining egg quality. On day 3, I had an FSH of 7 and my LH was 18. Everything I have read indicate that's a bad sign and difficult to correct. What do you think? So Jill, I would say not so fast. The reason is a high LH to FSH ratio could be a sign of something called polycystic ovary syndrome, which is super common. And it means that you might actually be quite blessed with lots and lots of eggs. If you know my personality, I tend to be pretty positive and kind of bordering annoyingly positive and optimistic. But certainly I wouldn't go there and say that your high LH means something bad, especially when your FSH is low. So what I would consider doing is an AMH test and seeing a specialist to evaluate if you have potentially polycystic ovary syndrome. And I've done some great interviews with Dr. Sasha Hackman and Dr. Dylan this past weekend. You can find them on my Instagram channel and Instagram Live. And go back and watch those videos. And we talk through the approach and care for women who have PCOS. And we teach you how to heal your PCOS so that you can live your best, healthiest life. And hopefully by learning those things, you then are going to have a higher chance of having a healthy pregnancy. So I hope that helped. So this next question is from someone who is saying, I'm 42 and doing IVF. Which supplements should I take for optimal results given my age? So I'll kind of tell you, let's see here. I actually happen to have a couple supplements right here in my drawer, and I'll just show them to you. One is called True Niagen. I have no relationship to the company, although they should call it Egg Whispergen. Because I feel like this is part of my special sauce, and I feel like I hear from people all over the country and from doctors as well about how their patients are benefiting from this. The other is pterostilbene, or something in this family. So pterostilbene around 150 milligrams, and I would say that taking that with high-dose CoQ10 and potentially micronized DHEA, and depending on what other things are going on, maybe NAC if you might have mild or even moderate or severe endometriosis. and then melatonin at night. So I know this sounds like a lot, and certainly your doctor can individualize a supplement plan for you. But I think the most important thing of all the things that I just mentioned is a prenatal with vitamin D and fish oil and CoQ10, and exercising most days of the week and eating healthy, and making sure that you're checking in with people around you, that you have a great community of people who will support you, because I feel like if you are supported and feel like you're validated with what you're doing, it just feels better to be a fertility patient when you're doing those things right now. And for you guys who haven't heard of Fertility Rally, be sure to go to fertilityrally.com. I'm doing a breakout session with them coming up soon, but I think they do a pretty amazing job supporting people who are going through fertility treatment, and they can be your fertility posse if you feel that you don't have one. Sometimes my patients who are 42, in the Bay Area, it's like everyone's 42, 43, 48, having babies. That's like not a big deal. But depending on where you live in the country, sometimes people look at you like you're a space alien wanting a baby at 42. In my world, you're not a space alien. In my world, it's called, that's normal. Okay. This question is from Melinda. Melinda is saying, when getting your antral follicle count done to come up with an IVF plan, why do some clinics recommend day 2 or day 3 ultrasound, but other clinics are not? They say it's not cycle day specific. Can you see less follicles if the ultrasound is done later in the cycle? Melinda, great question. Let me tell you my approach. My approach is, if your period starts, think of me, come on in cycle day 3 and see Dr. Aimee. I just came up with that rhyme maybe like 2 days ago, and I've been waiting to say that. So thank you, Melinda, for letting me say that. I like patients coming in around cycle day 3 because I get to also track and trend the hormone levels and check FSH, estradiol. Does it have to be day 3? No. When the AFC first came out as a test, we thought it always had to be done cycle day 3. And the answer is it actually doesn't. It probably stays the same throughout the cycle. However, when you're close to ovulating, sometimes that follicle count may not be as accurate, especially on the side that has the dominant follicle on it. And then sometimes you can feel kind of annoyed because someone tells you that your follicle count is lower than expected because of that dominant follicle. So in a case like that, if you're just going in randomly and you see a dominant follicle and you can't really see follicles on that side, don't worry, just wait and go back in another day. Right now with COVID, my recommendation is to make sure you're being seen by the clinic before you start an IVF cycle. A lot of our consults are being done, as you know, over video. I actually don't see patients in person. All my new patient consults are over video, but I am sure to schedule a pre-IVF ultrasound before my patients start their IVF cycles, because I want to get to know them and mostly their uterus and ovaries, and to make sure I'm not missing something big picture. So it would be really too bad and slightly annoying, well, really annoying, if you go in for your first baseline ultrasound, that's the first ultrasound you've ever had, only to find out you have this huge fibroid that you never knew about, or this huge cyst that you never knew about. So remember my mantra, I have many, they're all bumper stickers on my car, and that is pelvic ultrasound, please. Whether you're being taken care of by an OBGYN or a fertility doctor, even if it's your first fertility treatment plan with, let's say, Femara or Clomid, pelvic ultrasound, please. So go in, cycle day 3, get that done before you start your meds, especially if you've never had an ultrasound before. Thank you for that question, Melinda. This next question is from Erica. Erica's question is, hi, I'm 34 with 1 successful IVF fresh transfer from 2018. My AMH is 1.14, FSH is 9.9, and AFC was 13 in March. For some reason, I seem to be extra sensitive to priming. So after 1 canceled cycle due to poor response and 1 retrieval resulting in a normal day 6 blast, I'm gearing up for another retrieval. My RE wants to try a natural start. Is there anything I can do to make sure my AFC is strong? It hasn't been at 13 since March, more like 7 or 8. We tried testosterone priming and that helped a bit, but not much. My RE said that my numbers don't match how poor of a responder I am, and I just wanted to respond well. Thanks for any help. Erica, we got to change the language here. You're a fertile young woman. You have 34-year-old eggs. Having 7 or 8, I just hate the fact that someone's labeling you as a poor responder. And even if your doctor hasn't used those words, I want us to flip the language here and just think of yourself as a fertile woman with 7 or 8 eggs. Not necessarily label yourself with the number of eggs either. Our follicle count fluctuates from cycle to cycle. So it is possible that you had a cycle of 13 eggs and then now it's 7 to 8, and that's kind of the average of 7 to 8. And the 13 could have been just a fluke. Not necessarily a fluke, but that was just one cycle out of many or one cycle, and you may not see an AFC of 13 again, and that's okay. My recommendation is to repeat your AMH and see where you're at. Even if it's been 3 months or so since you've had it done, there can be lab variations in your AMH level that can kind of mislead or misguide you as far as what to expect from IVF. And 1 out of 5 women will have an AMH that doesn't match the real life experience or story. Like you can have a really high AMH and a low follicle count. That is possible. So your AFC will be more reliable as far as telling you how many eggs you will get from an IVF cycle. Take the IVF pyramid. You can go to my blog and print out the IVF pyramid from the article that is titled, "What is IVF?" Take it into your doctor and ask them to tell you what your IVF pyramid will look like based on your age, FSH, estradiol, AMH, and follicle count. These are the things that I do with my patients, and I know these are the things that other doctors would do with their patients as well. So if you were a patient of mine, what I would suggest are the supplements that I already mentioned earlier in the show. I would also talk to you about something called HGH and priming with that before your IVF cycle starts. Anywhere from even 2 weeks to 2 months beforehand, I've seen some great results for some women. I don't know why it doesn't happen with all women, but in some women, I have noticed that HGH priming might increase the egg count. It's not going to be by a whole lot. For some women, it might just be 1. For other women, it might be just the same the next month. So I don't want you to be disappointed if nothing changes, but there might be a cumulative benefit of taking it over time such that it might improve your egg quality. So see if that's something that your doctor would consider doing for you. And I do think a natural cycle start is something that I would do as well. And I'd also probably consider using a hybrid protocol. That's a combination of fertility pills and injections to help your eggs grow. So rather than starting with straight stimulation from the very beginning, you can consider a combination, for example, of higher dose Femera, like 4 tablets per night for 5 nights, and then introduce the injections after 2 or 3 nights of the Femera. This can be a way to help your eggs grow without stimulating them, or I should say overstimulating them from the very beginning, and maybe kicking off just 1 egg versus your whole cohort. So these are the simple things, and it sounds like your ovaries are asking for a different approach. And it sounds like your doctor is being very creative in what they're doing. So go back and say, what about HGH priming? What about a hybrid protocol? Some people call it mini IVF, but my goal with the mini isn't to stimulate you less to get less eggs. It's to still stimulate very well to get the starting number of eggs to grow. Someone asked me a really good question the other day. They asked me, Dr. Aimee, when I go through IVF, are you somehow causing me to run out of eggs faster? And I said, no, not at all. Nowhere close to that. I'm basically like Pam Anderson in Baywatch, running around in a red string bikini. No, I'm just kidding. Not running around in anything red. Red is not necessarily my color. Clearly you can see that my color is blue, and I would never be running around in a string bikini because my sister would not allow me to, because she would probably tackle me on the beach and say like, no, never do this. Just like I can see her saying right now that she doesn't like my hair, my nose is still too big, all of those things. Anyways, I digress. So thank you, Erica, for your question. I got very distracted by the jokes that I'm the only person laughing at. But my point is that, back to being Pamela Anderson, fertility doctors are egg rescuers. We're basically on the beach watching the eggs swim, and we're throwing out little life vests to each of the eggs. And we're not helping you or making you run out of eggs faster or anything like that. You won't go into menopause sooner. The only thing that I'm concerned about going through this process is not going through menopause sooner or cancer or any of the things that logical people ask about. And I get those questions a lot. It's really the mental health impact that treatments that don't work could possibly have on us. And so I say this over and over. Make sure you're asking yourself, look in the mirror. Am I okay? Like, really, am I okay? Look at your partner and be like, are we okay? And if the answer is yes, keep going. If the answer is no, I need a little help, make sure you get help. There's so many online resources. There's so many therapists that are like awesome. And they're probably like way funnier than me and don't have stupid jokes and can help you with the mental health aspect of going through IVF and being a fertility patient. So this next question is from Vanessa. Vanessa's question is, I'm 35 years old. End of 2016, I was diagnosed with DOR. For those of you who don't know what DOR is, it stands for decreased ovarian reserve, AMH of 0.25, and high FSH. My husband has male factor. We've done 3 medicated IUI cycles that haven't worked. We quickly moved on to IVF. We did an antagonist protocol, which yielded 6 eggs, 2 day 5 embryos. My first fresh transfer failed. Second FVT was a success. So now we're trying for baby number 2. My AMH is now 0.27, same exact protocol. We used agestin instead of birth control pills due to migraines I developed. Day 5 ultrasound only shows 2 slow-growing follicles, and they canceled the cycle. I have not found a new clinic that specializes in decreased ovarian reserve and poor response. Not sure if my protocol should change. Do you recommend birth control pills or priming? Do you recommend mild stems? I feel so discouraged and defeated. So Vanessa, we have a lot of good news. The good news is that you're only 35. My recommendation is to repeat your AMH and see what's going on. Add the additional supplements with the guidance of your doctor that I mentioned earlier on today's Ask the Egg Whisperer, and see about not using birth control pills in a case like yours. Consider doing HGH priming like I already mentioned. And yes, I do think a more gentler stimulation could help, especially if it looks like the follicle count that you have from which you can get eggs from is around 2. So why take high-dose medications? Sometimes you can accomplish your goals with just taking letrozole, which is similar to Clomid, which I don't use because it makes people feel like they need an exorcism once they're done taking it. So for the most part, using high-dose letrozole combined with maybe Menopur or Gonal-F or something like that could help you get your cohort of eggs to grow without using agestin or birth control pills. There's so many different ways of making a really good omelet or momlet. So I do think that there are other creative options for you out there. And the thing is that some cycles are just not good cycles, and you learn while you're taking the medications that you should just walk away. And in those cycles, you might want to consider still doing IUI potentially, depending on what your husband's sperm is like. But I would say keep going. There's still a good enough chance that it makes sense for you to keep trying. And then at some point, if you feel like this isn't working for you, there are obviously more creative family building options out there. It's incredibly unfair that we don't have a way to help women grow more eggs. I swear if men ran out of sperm, there would be a cure. Like, we wouldn't be doing IVF. There would be no such things as egg donor banks or egg donor agencies. It's a wonderful thing that they exist. No doubt about that. Like, no doubt. But I still feel like in 2020, there should be more that I can offer patients than just the things that I mentioned on this show. So this next question is from Stephanie. Stephanie says, hello, Dr. Aimee. I love your show. Very educational and knowledge-filled. I started my frozen embryo transfer protocol on September 22nd, had my baseline, my labs were perfect. Then I started estrogen, and my estrogen level on September 25th was 244. I'm on 3 milligrams BID of estrogen. My next appointment and scan is coming up on October 5th. Should I ask the doctor to add the suppository too? What supplements should I add? I'm already taking CoQ10, a prenatal with DHA, fish oil, vitamin C, and D. My embryo that I'm transferring is a 5BB as of now. I'm a little anxious but excited. Thank you. I'm very excited for you too. If this is the embryo that you have to transfer and you don't have other embryos waiting for you in the freezer for future options, my recommendation is to consider implantation testing. If you haven't heard of my Egg Whisperer diet, D stands for diagnosis. The I is your IVF cycle. E is embryo transfer preparation or endometrial testing, and the T is transfer. So it sounds like you probably already know your diagnosis and you've already done IVF, but this might be a good time to think about doing another cycle if you want more kids, or consider implantation testing, like the ERA test or the Receptiva test. So those are 2 tests that I do for my patients in cases like yours. I at least talk to them about it up front, Because the last thing I would want is to go through a transfer, have it not work, and then have someone say, oh, did you know that there's a test that could have given you maybe a 5 to 10% higher chance of pregnancy? I would be so mad. And I see it all the time because of the second opinion consults that I do for patients who've, let's say, had 2 or 3 transfers and haven't been successful. And then they come here and they find out that there's a test that they could have done that might have given them a higher chance of pregnancy. They feel like they were not given full informed consent before they move forward with their transfer. And it's not about doing every single test. It's just about talking through them and seeing what you feel comfortable doing. So talk to your doctor about that. I think your supplement list is great. I would just get good sleep, hydrate well, exercise most days of the week, all those things that your doctor also, I bet, is recommending for you. But talk to them about that implantation testing that I just mentioned. So this next question is also from a Stephanie. Stephanie is 39 years old and she has 5 genetic tested day 5 blasts, however, has not transferred yet because her lining is only 6 millimeters. She's tried 3 different protocols, twice using different estrogen protocols and one with gonal F. However, she ovulated early. Do you recommend a transfer at 6 millimeters or should I keep trying different protocols? In the meantime, I'm going to try a second egg retrieval. Okay, Stephanie, here's the thing. Try your second egg retrieval and ask your doctor if they would be open to doing a frozen embryo transfer in a fresh IVF cycle. You're like, what? And I'm sure your doctor has already considered that. You know what I'm saying. 5 days after your egg retrieval, thaw one of your frozens. If your lining especially responds really, really well to stim meds, I think that's a great approach. It sounds like your doctor is already thinking about that. And if you already haven't talked to them about that, be sure to ask them. If your lining is still at 6 millimeters, some of the things you might want to consider is a hysteroscopy to rule out Asherman syndrome, which is uterine scarring. Some of the strategies that I also use is make sure my patient is exercising, getting good blood flow to the uterus. If, let's say, I've seen women who have a higher body size, sometimes if they lose weight, the lining responds better to these medications and they get a nice thicker lining. If your body size, let's say your BMI is less than 26, for example, and you still have a thin lining and you've ruled out things like Asherman syndrome and your lining doesn't get thick even with IVF stim meds, some of the tricks that I've used are the following. Hyperbaric oxygen therapy, HBOT. There are tanks here in the Bay Area, and you go in approximately 5 to 7 times, about 1 hour each session. I have seen some pretty dramatic, impressive results in some of my patients. Also, the use of HGH has been studied that might help with endometrial receptivity in a case like yours. And since you have 5 embryos that are basically ready to be transferred, I have definitely seen patients who have a trilaminar texture at 6 millimeters who have had a successful implantation despite not having a lining over 7. Every clinic will have their own cutoff. For me, it's over 8 millimeters, but definitely I have transferred at even 6 to see a healthy implantation and live birth. So you're doing all the right things. I think doing another IVF cycle, not for more embryos, but just to help your lining thicken is a great idea. But obviously talk to your doctor about what you're going to do with extra embryos that you may not use. Okay? Great question. This next question is from Tanya, and Tanya says, hi, Dr. Aimee. A while ago, you answered a question I submitted to you about having higher testosterone in your blood, and you mentioned PCOS. I have a question. Are there any tests that would be able to diagnose it? Also, will taking Ovasitol help only after 90 days, or should I take it a little bit longer? Also, just wanted to say thank you for taking your time to read and answer my question. You really are amazing. Thank you, Tanya. That's really very sweet of you. And the answer is yes. PCOS, to me, is hope syndrome. Really, that's as simple as it is. And I'll break it down for you. The H is high androgens. So check the different levels of testosterone or types of testosterone or androgens in your blood. So there's free and total testosterone, DHEA, androstenedione. Those are just several of them that your doctor can check. O is looking at your ovaries and seeing how many follicles you have on your ovaries. The P is to look and talk to your doctor about your history of periods and see how regular your periods are. And the E is looking at eating and exercise. So Ovasitol can work almost as well in some women as metformin to lower testosterone and improve glucose homeostasis. Okay, so that just means improving your metabolic parameters. So I think of PCOS as something that you should heal look at what the hormonal imbalances are and fix them. And the healing should be maintained lifelong, because there are implications of having PCOS, for example, when you go through menopause. And if you don't address them now, when you're older, you might be at higher risk of having things like uterine cancer, for example, cardiovascular issues like having atherosclerosis. So those are the things, by treating it now when you're in your fertile window, would help improve your lifelong. Okay, so thank you for that question and your kind comment, Tanya. This next question is from Tammy. Okay, so Tammy asks, I started to bleed fresh red, not much to fill up one pad and brown discharge after. Should I be concerned? So Tammy, I don't know enough details about your period to know if there should be concern, but I think what you're saying is that you're worried that your periods might be too light. And because you're asking a question here, asktheeggwhisperer.com, I imagine you're probably trying to get pregnant as well. Easy. Well, it's not that easy, but figuring out the diagnosis, prognosis, and a treatment, I'd like to think is easy. Number one, get an ultrasound done. Take a look at your uterus, look at the lining thickness, and ask your doctor, is this lining normal or not? Two, look at your hormone levels. Sometimes having hormonal issues, like things that we've mentioned already, decreased ovarian reserve, can result in having lighter periods. So talk to your doctor about getting your AMH level checked, your day 3 FSH as well, looking at the cavity of your uterus, potentially with a saline infusion sonogram or hysterosalpingogram, especially if you've had an IUD removed in the recent past. That's something that can help guide you as far as what's going on and if you should be worried. But in general, it sounds like it's good that you start to bleed fresh red, not filling up a pad just for an entire day and that's it, the whole period, might be a sign that there's something going on. I'm not necessarily worried quite yet though, but talk to your doctor about getting these tests done. The last question that I have emailed to me is from Kaylee. Kaylee is asking, I'm struggling to get my IVF doctor to agree to do an ERA biopsy before my first FET. I'm finding this extremely frustrating because she told us to complete an abdominal MRI instead to check out a cyst, an adenomyosis or endometriosis, before she would even agree to the ERA. That test came back totally normal and they charged me $300. The ERA costs $1,200. We're fully aware of the price and are committed to still go ahead with the process. However, she continues to say our request for doing it is useless or unnecessary, and she doesn't understand why we would want that test. We've never had a miscarriage, but we want the test because our embryo score going into the FET is low. What should we do? Should we get a new doctor? So this is the thing. It is really hard to get someone to do something for you if they don't believe in a test. What that means is she hasn't done the test in enough patients to see a benefit from doing it. I started doing the test in 2013. The test wasn't even available on the market. I had a patient who had 5, not 1, not 2. She literally had 5 embryo transfers before meeting me. And I was like, okay, I got to figure this out because something is just not adding up. Her window of implantation, so I called actually, I saw a Google alert because I have Google alerts for everything related to fertility. I got basically a Google alert about this test called the ERA test, and I called the company. I said, I want that test. I have this patient, and I need to see if I can help her with this test. I did it. Her window of implantation was 48 hours shorter than I would have expected. I would have never have given her basically 3 days of progesterone for a day 5 transfer. Never in a million years. I didn't believe it. So this poor woman, I put her through, yes, a second ERA test. I did that to her. And again, the results came back the same. She had run out of all her embryos, so we had to do another IVF cycle, and she still couldn't believe that she could ever get pregnant through IVF. So what I did is I said, well, I'd like to transfer 1 embryo. Let's just see what happens and apply the rules from the ERA test to this transfer. And she said, no, I don't believe that it's ever going to work. So I'd like to transfer 2. She now has twins, long story short. So my point is that the test could be helpful. It's only time out of your life, and it might improve chances by around 5%. So there is a study out there, and if you message me privately, Kaylee, I'll send you a study that was recently published showing in people who did the ERA test before their first embryo transfer, they might have a higher chance of pregnancy. And I know there are doctors that say they don't believe in it, and that's okay. But unfortunately, when you've put yourself through so much and this is your embryo, you own that embryo and you get to say what you want to do before you transfer it. So you can always do your ERA test with another doctor and then go back to your original doctor and have them apply the ERA rules to your transfer. I don't see anything wrong with that. I have been doing that for patients for a really long time, and what's really amazing and wonderful is the doctors who said they don't believe it, guess what? They're doing the ERA test now. So that's pretty awesome for me to see. And I just hope that more and more people will at least be talking to their patients about it and giving them the option to do it and giving them the information so they can research it online, talk to other people and their partners and seeing if that's something that they want to do. Okay, guys, so thank you for all your emailed questions. You can go to asktheeggwhisperer.com and I will answer your questions again. I'm going to do this more this week. I think I'm doing this again on Thursday and Friday. So I'm going to scroll through and answer the questions that you guys have live chatted right now. Here we go. Are Menopur-only cycles good for egg quality? Yes, Britt. I do think Menopur-only cycles can be fabulous for egg quality. I have noticed if I increase the amount of Menopur, and I've been doing it for years, I'll get better quality embryos than in cycles that are more FSH dominant. Of course, talk to your doctor because every doctor will have their own style and will truly, we all believe in what we do. Otherwise, we wouldn't be doing it. So I'm always going to think that what I'm doing I'm doing the best for my patients, and I'm sure your doctor thinks the same. But you might want to ask them to add a little bit more Menopur if that's what you're thinking of doing. So this is a question about what NAD supplement should I use and how much. So I use this one. It's called True Niagen, and it's 300 milligrams. Oh, here it is. Here's the bottle. So it's also blue. I'm matching. It's as if we planned this, and I totally did not plan this. But this is the bottle that I have here. 300 milligrams, so I take it every single day. And sometimes I have to take a short break because I'm kind of already very high energy. And then me on True Niagen is like kind of up a notch, and that gets slightly annoying. So I'm that person that's like, I'm up at 5 and I'm like to my husband, are you awake? Are you awake? Are you awake? Are you awake? What are you doing? What are you doing? Where are you? And that can be really annoying to live with someone like that. But sometimes I actually want to sleep past 5 a.m. So because it sometimes wakes me up and I just can't go to sleep, I'll take it every other day. But you can get it in a 150 milligram dose or 300 milligram dose. But I would suggest there's so many different companies out there that are making it, but realize that some of them will cause you side effects, some of them won't. So find one that doesn't cause you side effects. So here are more questions. Let's see here. Someone's saying, my skin looks good. Well, thank you. 48 is what I like to hear about having babies. Excellent. I couldn't start my next treatment because I have a cyst and estradiol is 446. Do you think that could affect my treatment during my 2-week wait? Because that's when the cyst started to grow and the estradiol went up. I would say the estrogen normally goes up, and it is something that's essential for pregnancy, and having a high estrogen level won't hurt a pregnancy. So I don't see that as something that would hurt. So someone is saying, I never got emails back, so not sure my question went through. So your question went through, but once I get a set of questions and I want to make sure I answer all of them and have time to answer the live chatted questions. So you'll definitely get an email when I'm going to answer it. So it should be this week. So thank you. So this is from Erica. I was just diagnosed with MS, 36 years old, AMH 2.8. Should I wait before going on a drug that is contraindicated for conception? Sperm is normal, removal of uterine polyps. Should I consider egg freezing? So Erica, one of my Egg Whisperer golden rules is this. Anyone who's 32 years old and partnered who wants to have at least 2 kids should strongly consider freezing embryos. It sounds like the medication that you're on is basically fertility threatening. So I would absolutely consider freezing eggs. I don't know what I was about to say, but eggs, embryos, or both before you start that medication. Your AMH is awesome, but if you think about things and plan your future, your 39-year-old self would be like, Erica, great job freezing your 36-year-old eggs. I know every single 39-year-old woman that sat in my office would tell you, go freeze eggs or embryos. You won't regret it, especially with such a healthy AMH. So I would say, go for it. So next question is, let's see here. Hi, Dr. Aimee. We had 19 eggs retrieved, 11 embryos. I'm 29. How many do you think we will have after PGT? Okay, Emma, so this is what I think. With 11 embryos at the age of 29, assuming you have a normal chromosome analysis and same with your partner, and there aren't any other factors like endometriosis, I imagine you could have maybe even 6 blastocysts come back, PGTA, with normal chromosomes. It could be even more. I mean, the viability of each blastocyst at 29 could be upwards of like 65%. So I would not be surprised if half or more than half of your embryos come back with normal chromosomes. So I hope I'm right. Next question is, hello, do you think acupuncture can help with strengthening a cervix while pregnant? Thank you. When it comes to strengthening a cervix while pregnant, I'm not really sure that acupuncture can help. I think things like decreasing stress, that can help, not necessarily strengthen the cervix. Acupuncture can help with the symptoms of pregnancy, so you're not throwing up all the time. So my patients who do acupuncture are less nauseous and don't throw up as much. So that might help with strengthening your cervix. But as far as strengthening your cervix, not so much. I would say acupuncture and helping with all the joint pains and all the symptoms of pregnancy and all the hormones that you might be taking if you went through IVF, perhaps. So I do recommend acupuncture for my patients, but not for the indication of strengthening the cervix. So here's another question. I just had a failed IVF cycle, unexplained infertility. My naturopath says my immune system may be attacking the embryo. So if you had a failed IVF cycle, you guys know that I have the mnemonic, diamonds, embryo diamonds. Go back to your doctor and make sure you have all the information. What day your embryo stopped growing or were frozen, what the implantation rate is per embryo, which ones are abnormal, which ones are mosaic, and make sure your clinic has a protocol in place for reporting mosaic embryos and for transferring them. Make sure you have the official reports. Make sure you know which ones were normal. Obviously, it sounds like these embryos did not help you reach your dreams. And then ask about sperm on the day of the egg retrieval. Ask your doctor, what is my diagnosis? What did we learn from this cycle? What are we going to do differently? And then be sure you have a plan that you feel really comfortable with. Right now, with what's going on with COVID, I find that it's harder and harder to communicate with people, meaning I can share information with them, and it's hard to talk with a mask on, but I feel like it's harder to hear things. So what I like to do is verbalize information, email information, and then also provide articles and even videos to help reinforce the topics that I'm sharing with my patients. So if you don't feel like you're getting that type of communication, please ask for it. Ask for written summary of your body and what's going on. Ask for a written plan as far as what the next steps are. And then ask literally like, what are my next steps? For me, I have a van outside that says, if your period is here, follow me. And it's true. I don't, but it feels like that. I mean, I love what I do. So I feel like anyone who's on their period who wants a baby, I need to help them. So I'm like, get in my car. Let's go to my office. That would be really weird, you guys. There's no way that that's happening, but you know what I mean. Next question is, I'm 46 years old. I did 3 natural IVFs, all just Clomid, Letrozole, Lupron trigger, no positive results. I'm thinking to try, I don't know what this is, TINY inputs. Sounds cool. All my IVFs resulted in 1 embryo transferred at day 3, thanks. Okay, so at 36, what I would say to you is we need to have realistic expectations. When a 46-year-old comes to me, I'm like, girl, if we get pregnant together, we're going on CNN. Because that's the reality of how unusual it is to be successful at 46. I personally have never had a patient do fertility treatment with me that has reached their goal of having a successful pregnancy with their own eggs at 46. One day, I hope I can say, I now know someone who is successful at 46. So rather than trying all these experimental treatments, I would say talk to your doctor about creative family building options. And the reason is, I don't want you to spend your 40s and your youth being a fertility patient. I want you to get pregnant and have a baby right away. So guess what? You can have a baby right away 1 or 2 years later. So that would be pretty awesome to have 2 kids under the age of 50 rather than spending all this more time doing more treatments that probably won't work. You can never look back and say that you didn't try your very, very best. But doctors are medical doctors. We are not medical deities, and none of us is a superhero. So the likelihood of being successful at 46 is probably 0.01%. It's definitely not zero because I'm still trying to get my single live birth. And I do try probably at least 100 patients a year, literally. But my patients, what they appreciate is this honest feedback, and they know that they at least tried their very best. So this next question is, my clinic is doing batching. They put me on estrogen priming on cycle day 17, night after drying progesterone that day. It was 14.5. They're going to start stim on cycle day 26 this Sunday without waiting for the start of menses. Can you start stim this way? And the answer is you totally can. You don't have to wait for your period to start your cycle. There's so much experience now with something called mid-luteal starts. And you're not doing a mid-luteal start, but sometimes doctors start cycles even before the period starts because there are some patients who recruit eggs really early. I'm not thinking or seeing that that's something that you do, but that definitely is a strategy that you can use. And potentially their batching cycles, they need to get you in when the embryologists are there so that they can accomplish your egg retrieval. So that could be why they're starting your stimulation a little bit early before your period starts. I don't personally like to do that. And the reason why I don't like to do that is my patients like the numbers. They want to see what their FSH estradiol levels are. And if you're doing what you're explaining to me that you're doing, you're not going to get those data points to be able to say, should we move forward with this cycle or not? But that is still a way of doing IVF. This next question is, which is better to transfer, a 5AB or a 6AB embryo? And I think they're both fine. Find out which one's a day 5 and which one's a day 6. Maybe transfer the day 5. Ask your clinic which they think will have the higher survival rate and give you the best chance for a live birth. But they're both pretty darn awesome. Excellent. Okay, I see. Zara is saying I got an email to say my question would be answered, but it wasn't read out. Zara, I don't have it here. Oh my God. Look, I have page 3. Zara, I totally suck. You rock. Thank you for that. I actually have a 3rd page to my questions that I totally missed. So I'm going to go here and answer them. This is from Zara. Zara, thank you. Your question is this. I'm 38 years old. I did IVF number 1 in February. I have stage 4 endometriosis, endometrioma, adenomyosis, and polyps. Surgery number 1 in August 2019 to correct it. Surgery number 2 caused an infection. I had a 10 centimeter abscess in my ovary in May of 2020. Holy smokes, Zara. Surgery number 3 in August of 2020 to remove both tubes. AMH January of 2019 was 28. AMH was then 21. I got 10 eggs, 7 fertilized, 2 good quality blasts and frozen on day 5. 5 remaining on day 6, 2 arrested, 3 not good enough to freeze. What is your advice on next steps? Embryo transfer protocol. Another egg collection, perhaps? I want more than 1 child. My partner is 47, no issues. I take CoQ10, 200 milligrams, prenatal. My day 2 FSH was 10.4. Okay, Zara, here's what I would do. I would consider another IVF cycle. I really would. And then before you even transfer, it sounds like you did the work already to remove the fallopian tubes, which was a great idea. Because if the fallopian tubes were, let's say, filled with fluid, that could cause a lower implantation rate. We know that when your fallopian tubes are dilated and inflamed, that can cause a more hostile condition inside the uterus. And having that done ahead of time is great. I'm really glad you did it. Since you've obviously worked so hard for your embryos, even in the UK, you can also ask for the ERA test. There are doctors in London who will do it, as well as the Receptiva test, because I wonder, why were your tubes blocked in the first place? We know the answer. The answer is endometriosis. You told us. You told us you had stage 4 endometriosis and an endometrioma, adenomyosis, and polyps. If you don't have access to a test to look at how much or how little inflammation you might have in your uterus, I would consider even doing 1 to 3 months of Depo-Lupron before you transfer. I imagine your doctor is going to say the exact same things, but I would make sure you've done a cavity evaluation like a saline sonogram, implantation testing if your doctor thinks that that's okay for you, and then consider some sort of suppression for endometriosis. But do this after your next IVF cycle. women with adenomyosis might have a lower chance of implantation and a higher risk of miscarriage. So make sure you ask your doctor, how severe is my adenomyosis? You don't want to find out after a transfer that embryo never would have had a chance to work. It's super important to ask your doctor, what stage is my adenomyosis and what do you think my implantation rate will be for my embryos given my adenomyosis? And what can I do to improve my adenomyosis before I transfer? Because we know it doesn't go away. We know that after the surgery, it can certainly not progress as fast because all the endometriosis was removed around it, but we know that IVF and estrogen feeds adeno. So whatever you can do to prevent the progression of your adeno, and the things that you can do are to take supplements like N-acetylcysteine. I recommend to my patients around 600 milligrams per day, and then some sort of suppression to prevent periods so that the adenomyosis doesn't get worse. If you were my patient, I would also, with your stimulation, consider having you take Femara every single day during your stim. Letrozole or Femara, they're the same thing, have been shown to treat endometriosis and reduce the amount of estrogen that is seen by your uterus, and that might help in a situation of yours. So talk to your doctor about the strategies that I just explained, and I'm so glad you pointed out that I still had page number 3. Zara, I hope this helped, and thank you again for pointing out that I missed your question, because I missed 2 more. So this question is from Kay. Is there a difference, or what is the progression of ovarian reserve in a patient with PCOS at the age of 33 versus the same patient a few years later at the age of 37? Is a patient with PCOS susceptible to higher rates of ovarian reserve depletion over time? Does the degradation process or depletion in egg grading quality during the thaw process have negative effects on implantation success rates? Is there a correlation to egg grade changing during thaw and success rate of the implantation becoming a positive pregnancy? Great question. So when it comes to PCOS, everyone is different. So I have patients who are 37 years old with PCOS who I can get like 9 or 10 embryos that have normal chromosomes. But then I have patients with PCOS at 37 who I'm struggling to get even 1 to 3 normal embryos with having like over 20 eggs. So I wish there was a better test that we had before we started IVF to know exactly what situation you were in. Unfortunately, the best thing that we have is just your age, and we know that the egg viability for each egg at someone's age is basically dependent on their age. I know I just said something like a whole bunch of different times and went like a bunch of different circles, but I think you totally know what I'm trying to say. So for some people, their ovarian reserve goes down pretty fast than other people. And we know for everyone, our rate of egg loss tends to accelerate after the age of 37. And I've definitely seen women who have PCOS not have that same rate of egg loss. So I hope that answers your question. As far as embryo thawing, the embryo quality has a lot to do with how well it will survive the thaw and how well it's going to do the day of the thaw and then after. So ask your doctor the implantation rate per embryo. The survival rate in the labs that I use is around 99.5%. Even poor quality embryos will survive, but embryos that are really poor, like really, really poor, sometimes don't survive very well, and it's because they barely survive and they basically stop growing because they were so poor quality in the first place. So the cells weren't that stable and strong to begin with. So that's why before I even put an embryo through a freeze, I always ask myself, is it something that this embryo can sustain and then turn into a healthy pregnancy? Because I have cases where I prepare my patients for a possible fresh embryo transfer, and we don't do a frozen embryo transfer. So that's sometimes a thing that you can talk to your doctor about after the egg retrieval. Should I still take hormones to prepare for a fresh transfer if my embryo doesn't look like it's good enough to freeze, but still basically barely viable? So those are the things that you can talk to your doctor about. This other question is, our doctor keeps suggesting we do an endometrial scratch biopsy to test our natural killer cells, which is a test that can be done through a blood test. Why would we need a biopsy for this test? What are the benefits or disadvantages of doing it? Would I do this test in replace of the ERA? If not, why not? We also just started IVF round 3. I requested our embryology team split our batch of embryos at day 4, freezing some and letting the other go to day 5, 6 to get the blastocysts to be PGS tested. Our embryology team is willing to try this with freezing some good embryos at Moyla. However, our specialist overseeing this thinks that this will give us false hope. I'm approaching 34. So what I would say is I would not ever freeze a morula. It doesn't make sense because you really don't know what it's going to be. Waiting one more day or even to day 6 is exactly what I would do as well. It doesn't make sense to split them in half. To me, I would just say let them all go to day 5, 6, or 7, reach the blastocyst stage, and then freeze them, because then you really know exactly what you have. You know how many viable embryos you have. Even if you're not doing genetic testing, that's okay. As far as doing the endometrial scratch biopsy to test your natural killer cells, that's not quite making sense to me. In this country, to test natural killer cells, the only thing we have available is a blood test. In other countries, there is a natural killer cell endometrial biopsy that you can do. I wish I had access to that because honestly, natural killer cells in your blood probably don't mean that much, but the levels at the lining are actually where it really matters. So hopefully one day I'll have that tool for my patients, but if you have that as a possible test, why not? Take advantage of it. But also ask your doctor if they could do the ERA test at the same time. I don't know that a scratch alone would be that helpful, but getting more information from the scratch as a test, that seems like it could help. So here's a question here. Is 42 too old? And the answer is it just depends on your AMH, your FSH, and estradiol. If you still have eggs left and you don't feel like it's too old and you want a chance at pregnancy, go for it. Most women have a really hard time getting pregnant at 42, no matter how great you've taken care of yourself. It just has to do your age and genetics and environment. But for the most part, if you feel like you want to have a chance at pregnancy at 42, go for it. So we have a few more chatted questions, and I'll just make sure to get through them before we sign off today. This is a question of, do you have positive experiences with women who have been diagnosed with a unicorn uterus? And the answer is yes. But the decision I make as far as how I prepare for transfer is very careful and cautious, and I also want to make sure I have enough embryos for them to reach their family size goals, because the thing is this, they may need more embryos to achieve a live birth compared to someone who doesn't have a unicorn uterus. So this is a question. My doctor recommends 1 month of Depo-Lupron before FET, and then they'll do the ERA. They also have me do 1 month and 1 month for the actual transfer. I get it. Yeah, I would totally do that as well. I agree with that plan. Hi, Dr. Aimee. Can several aura migraines affect baby development during first trimester? So I don't see that aura migraines would affect the baby. I would just say that ask yourself, why am I having migraines and what can I do to treat it? If it's lack of sleep, if you think about it, okay, perhaps lack of sleep can potentially affect baby if you're just delirious. I don't really think that that's a thing. But I would do whatever you can to get treatment for your migraines. There's so many things that you could do. For example, Furoset is one example. Furoset with codeine. Acupuncture would be something that can help. But at the end of the day, sleeping is one of the best treatments for migraines. If I was in charge of the world, I would give every single woman first trimester leave, so that if you have a migraine, you just go to sleep. And certainly a little bit of coffee can also go a long way when you have a migraine, especially in pregnancy. So someone is asking, despite doing the ERA and having a good grade embryo, is there any chance implantation may not work? And I would say yes. With chromosome testing of embryos, we're not necessarily checking things at the highest resolution that is physically possible, because embryos are super tiny. They're microscopic, and we can only get so much information from these tiny little microscopic embryos. So we might be missing serious chromosome issues that could result in the embryo not growing and not implanting. So while the technology is good, it is certainly not perfect. So that's why I call genetic testing of embryos the murkiest of crystal balls. So it's super important for you to talk to your doctor about the accuracy and sensitivity of these tests and what your chance of pregnancy is based on your embryo diamonds. Remember that analogy that I gave you. Ask about the implantation rate per embryo due to the quality that it's been assigned, and ask for them to explain the quality report for each and every one. And do not ever let anyone tell you that quality doesn't matter, because that just isn't true. Your embryo quality, if someone says your quality doesn't matter, then imagine going into like a diamond shop and saying every single diamond here is the exact same price. It doesn't matter how big it is or, the clarity of it. That's how silly it is to me for someone to say that embryo quality doesn't matter. At the end of the day, embryos that aren't good quality, that have normal chromosomes, could still turn into a healthy pregnancy. I've seen it with my own eyes many times. But we know that higher quality embryos have a higher implantation rate. There's no doubt about that. Next question is, can you please provide any first trimester tips? So first trimester tips is to rest really well, especially now with COVID. I'm taking all my patients who have to go into work off work. I want you to decrease your stress as much as you humanly can. Consider acupuncture for any of the symptoms of pregnancy that are causing you distress. Talk to a therapist during first trimester if you're starting to have, especially if you had a really tough fertility journey, you might have problems with depression and anxiety. Supplements like magnesium can help with sleep at night. Unisom can help with nausea. Tracking and trending your HCG and progesterone levels can sometimes decrease that anxiety. And doing early ultrasounds frequently can also help you by seeing your baby's heartbeat early and then following up with it every 2 weeks or so, especially if you had a miscarriage, can kind of make the journey a little less distressing. So I'm going to sign off after these last 2 questions, and I love that you guys have so many questions. I'll probably be here again on Thursday. I mean, I should. If I can find another blue dress. I think I will. So second to last question. I only have 1 to 2 day periods. Does that mean my lining is too thin? What can I do to make it thicker? So what I would do is get a pelvic ultrasound, especially around ovulation time, because that's when you'll know if your lining is too thin. Get your hormones checked and see if there are any abnormalities, because sometimes a hormonal issue could cause a thin lining as well. Look at your diet and your body size and lifestyle, because those things can affect your lining too. Last question is from Right of Life. 35 years old, first cycle, 14 eggs retrieved, 11 fertilized, 4 blasts, 3 normal, second cycle, 8 retrieved, 6 fertilized, 2 blasts, waiting on PGTA, just wondering what happened to the amount of eggs. So what happened is that nothing. You're just super lucky. We talk about IVF as, a lot of people think of it as you just lose things over time, but what you're gaining is things that you've never had before. So it's super normal to start off with 14 eggs to end up with 3 embryos that have normal chromosomes for someone who's 35. That's called being human. And that's how IVF goes. So if you don't know about the IVF pyramid or the IVF attrition pyramid, go to What is IVF in my website, Dr. Aimee, DRAIMEE.org. Print it out, take it to your doctor. Because if you were my patient and you had 11 fertilized eggs and 4 blasts and 3 were normal, I would be like, holy smoke, girls, we just hit the jackpot. Your eggs are sparkling. So I would say that what happened is something amazing, and you are in great position to have IVF success. So thank you guys for all your questions, and I look forward to coming back again on Thursday. It's already Tuesday. It feels like Friday though. I'm just kidding. I love what I do, and I know how hard it is to be a fertility patient. So I want you guys to be sure to find the strength and resilience that you need to keep going. You're obviously watching me on this show, so I know you have it. And ask yourself, am I okay? No, are you okay? Are you okay? Ask your partner, are they okay? And if things are not okay, make sure that they become okay. Because at the end of the day, it's always going to be okay. So learn how to do deep breathing, meditation, exercise, be outside as much as you can, and make sure to find your community during these really tough times. It is super important. And come back and watch me here on Thursday. I'll try and find better jokes, and I'll try and get better hair. Probably not, though. The jokes, maybe. I'll read a joke book before I come on. So thank you guys for joining me. I love you all. Keep sparkling, and I'll see you back here on Thursday. Bye, guys.